Good evening, everyone, and welcome to our webinar tonight, Reimagining Residential Aged Care in the Wake of the Royal Commission. I'd like to start tonight's meeting by acknowledging the people of the Wiradjuri Nation and the different nations on which each of our participants meet tonight. We're committed to working in the spirit of partnership and collaboration with our region's Aboriginal communities and peoples to improve their health, emotional and social wellbeing. I warmly welcome Aboriginal and Torres Strait Islander Australians who are present here tonight with us. Just a few housekeeping points before we get started. If you can't see your control panel, just click the small orange arrow that should be at the top right of your screen. If you have questions, we'll save them until the end of the professor's presentation, and just use the questions box to type those in. We're recording tonight's webinar. Tonight's presenter is Professor Maria Fiatarone Singh, who we're very fortunate to have here with us tonight. Maria is a geriatrician and she's held the inaugural John Sutton Chair of Exercise and Sport Science, Faculty of Health Sciences and Professorship, Sydney Medical School since 1999. Her research, teaching and clinical career is focused on the integration of geriatric medicine, exercise and nutrition to improve quality of life in older adults. And she's recognised internationally for this work spanning over 3 decades, which is quite amazing. She's designed and carried out many clinical trials and longitudinal studies in Australia, America, Norway and France, including large multi-centre trials of exercise and chronic disease prevention and treatment. She's published extensively, having authored and edited 3 books and over 400 peer-reviewed publications with an H-index of 73. She's also been awarded research funding exceeding $71 million to conduct research internationally. And we're also very lucky on our panel tonight to have Beth Jeffries, who's a dietitian who's worked for a long time in rural areas, and for the last 10 years she's worked privately in nursing homes. She's based in Bathurst and provides services to the surrounding areas, and she also sits on the Agency for Clinical Innovations, Nutrition and Frailty Reference Group. We also have with us Gabrielle Mcnamara, who's an OT, and she's worked for over a decade in a variety of settings, public and private sectors, and working with older people has always been a big part of her work, and she now specialises in working with older people who experience severe and persistent mental illness as part of the Pathways to Community Living Initiative Health Reform. So welcome panel, thank you so much for joining us as well. I'm just going to throw you to you now, Maria, to presentation.
Okay. Could you see my slides okay?
We can see them, yep.
Okay, great. Well, thank you very much for the opportunity to be here tonight. This topic is very close to my heart, mainly because this beautiful woman here, my grandmother, unfortunately suffered at the hands of the residential aged care system in America after having a hip fracture. And there were innumerable times that my brother and I, as teenagers, went into the nursing home and took off the restraints, threw them in the dumpster, and tried to get the Haldol out of her system. But luckily, we were able to return her to us for the last, sorry, this is not going forward. There we are. For the last 8 years of her life, despite having been through this traumatic experience. So she is the reason I became a geriatrician at a time when, in fact, when there was not geriatric medicine as a specialty. So as always, my career has been devoted to her and to trying to avoid what happened to her for many other people. So in the words of Walter Bortz, who also, like myself, is a geriatrician and a good friend, the mission of medicine, as I see it, is the assertion and the assurance of the human potential. And it would be nice if the way that we took care of our older loved ones lived up to that mission. And unfortunately, I think in most countries of the world, that just isn't the case. And certainly the Royal Commission has uncovered some major gaps in this mission, which we'll talk about tonight. So unlike Walter Bortz, a lot of people do age in a way that isn't so healthful and aren't lucky enough to be able to be a marathon runner at the age of 90 and look more like this. And obviously, frailty is something that is a bit hard to define, but we know it when we see it. Of the many definitions, the Linda Fried definition is probably quite apt for the topic that we're talking about tonight. So this combination of shrinkage of muscle, slowness, strength loss, sedentariness, and sleepiness are really the 5 phenotypical characteristics of frailty that we are all very familiar with, and which obviously lead some people into residential aged care. And I think the most important fact that we need to come to grips with is that we really have no drugs for aging, frailty, mobility impairment, and many of the comorbidities that you see on the screen. All of these things, which are so important to quality of life and to the ability to live independently, are things that we need to approach in a very non-pharmacological way. And certainly a large portion of older adults globally, something like 50% of the 1.6 billion people over the age of 65 are projected to be frail by 2050. So we certainly need a better way to figure out how to approach this problem. And central to many of the features of frailty is the loss of muscle strength and power and muscle mass with aging. And you can see from this graph from the Baltimore Longitudinal Study on Aging that particularly in women, we lose muscle power even more than muscle strength, so that by the age of 70, 3/4 of the muscle power that you would have as a young adult is gone. And with that loss of muscle power comes many of the attributes that we recognize as frailty. So if we look at the Asia Pacific guidelines for how to manage frailty, which all of you are familiar with, we'll see that many of them actually circle around this concept of reduced strength and sarcopenia, because it is so central to the underlying characteristics that we know about. So frailty defined as a state of reduced strength, which increases susceptibility to many other bad outcomes, overlapping with sarcopenia, which you see on that CT scan there, so that there is a lot of overlap between how we would treat each of these conditions. Because of this centrality of muscle strength, the recommendation for using an anabolic form of exercise, resistance training, as a way to combat that becomes, again, very central to the treatment of frailty, and where it exists under nutrition, obviously part of that loss of muscle mass and function as well. So the recommendations, which again, all of you are quite familiar with, very strongly emphasize this role of resistance training exercise, and as part of perhaps other kinds of exercise, but a very central role for this particular kind of exercise, as well as looking at polypharmacy and deprescribing as, again, central to improvement in quality of life and function. And for those who are losing weight, looking at ways to improve nutritional intake. So very clear what frailty is and what are the management guidelines, and we'll look and see how that intersects with what the Royal Commission has found. So diagnosing frailty, part of the problem is that we're not that good at diagnosing it throughout the healthcare system. There are simple ways like the Frail Scale from John Morley, which really can be administered in a couple of minutes. And again, you're probably quite familiar with this. And you can classify people relatively well as robust, pre-frail, or frail. So what does that look like? Well, we'll take a look at Sylvia, who's a participant in the Strong Medicine Clinic at Balmain Hospital for many years. In this picture, she's just shy of 96 years of age. It was taken a week before her birthday. She has a quite complex and long medical history, which you can see there. And so perhaps if you're thinking about the accumulation of chronic diseases as a pathway to frailty, she certainly looks like somebody who might be on that pathway. But if you actually administer the Frail Scale to her, she has no fatigue, she has no weakness, she has no ambulation difficulties, and she has no loss of weight. She does score enough chronic diseases to give her a point of 1 on this scale, so she would be pre-frail. luckily enough, she's run into Nathan DeVos 11 years ago at the Strong Clinic, an exercise physiologist. And so she has been actually practicing resistance training exercise for the past 11 years, from the age of 85 to 96. And we know that if you look generally at what happens to muscle mass with aging, there is this looking like sort of inexorable decline of muscle mass over the lifespan. And this is studies of people who aged without any chronic diseases and died suddenly without any illness. So even healthy aging is associated with significant loss of muscle mass, particularly after the age of 70. This is Sylvia's graph of lean body mass over the past 11 years. So here she is at age 85 and 96. And you can see that in contrast to that very typical sarcopenia that occurs with aging, Sylvia has actually not experienced that at all. Why would that be? Well, she's certainly aging in a very different way in terms of her exercise habits to most people of any age, but particularly most people of age 96, by virtue of participating in weightlifting exercise 2 to 3 days a week for the past 11 years. So Sylvia certainly is not typical of people who are recipients of residential aged care, who often do not receive the kind of medical care and certainly allied health care that she has. And as you would know, the Royal Commission has stated quite clearly that the kind of preventive and holistic care that is needed is really not being offered to people in residential aged care. If they have care needs, they're identified, if at all identified, they're identified quite late. Obviously, people can't access and travel to services that they need, and some of these aged care providers are also not willing to travel to older adults. So there is certainly a dearth of particularly preventive and holistic care, such as we saw with Sylvia, which has been very, very vital in keeping her active in the community. So the final report obviously clearly states that people in aged care have far too limited access to allied health, including all of the different professions you see there. And that lack of care is really a major part of the problem. So nursing homes really should not be the denizen of physicians solely, although physicians are important. You don't need to see a doctor every day, but what you do need is to see some of these different allied health professionals on a far more regular basis than people typically do in aged care. So this is about reimagining aged care. I actually imagined aged care to be possibly quite different a long time ago, when I thought I needed to do something to prevent what happened to my grandmother from happening to other people. And so in 1988, I actually went into a nursing home in Boston and did a study of high intensity weightlifting exercise as well as nutritional supplementation, because it was quite clear that the people living in that nursing home were insufficiently being looked after in terms of their physical activity levels and their nutritional intake. And they were old, they did have lots of chronic diseases, but what was really killing them was the inactivity and the nutritional depletion that they were experiencing. And so in this nursing home study, which we followed up with a larger one, we saw that there was a very strong relationship between how much muscle mass the residents had and how strong they were in their lower body strength. And so this loss of muscle mass and strength, which we see is very, very central to frailty and is the definition of sarcopenia, was very clearly present in these nursing home residents. So what do you do when you have low muscle mass and muscle strength? Well, the antidote is quite clear. It's been clear since 1945, when Thomas DeLorme first invented the phrase progressive resistance training and applied it to Army recruits who were having knee surgery. But it seemed very clear to us that that very same pathway of trying to overcome sarcopenia by making people overcome an uncustomary form of resistance or lifting heavy weights was really what these nursing home residents needed. And what we found was that not only were they able to do this kind of weightlifting exercise, but they had major changes in their musculoskeletal system in a very short period of time. And I was pregnant at the time, but this is my second favorite baby here. This is a Myoblast You can see, and a myotube or two myoblasts are forming together. So these muscles of these 90 and 100-year-old individuals were still able to produce hyperplasia and hypertrophy after exposure to very typical kinds of weightlifting exercise. And that growth in the muscle was accompanied by a growth, by a change in muscle function. So we could see a doubling of muscle strength in the group that got exercise, and even more increase in strength in the group that got exercise plus a nutritional supplement. Supplement by itself actually did not cause any improvement in muscle strength. So just giving more calories to people was not the answer. And the control group, who got a very typical kind of gentle exercise class offered in a nursing home, as well as a non-nutritive sham supplement, also, as you might expect, did not have any improvement in strength. So this doubling of muscle strength, which represented about the loss that these people would have had over a decade of life, was very easy to reproduce with very typical kind of weightlifting exercise. And we were also interested in what would happen outside of the exercise class. And it turned out when we put activity monitors on their ankles that the people who'd gotten the weightlifting exercise without any advice to walk more, to do any other kind of activity, walked about 35% more around the nursing home compared to the people who didn't get the exercise. So just giving people the strength back that they needed in their legs was enough to actually get them to be more mobile and active in their residential environment. In terms of the supplement, what we saw was very interesting because we did measure very carefully what their normal dietary intake was with 3-day food weighings. So very, very precise measurement of dietary intake. And it turned out that if you live in a nursing home and you do weightlifting exercise, you don't eat more because you're not really offered any more food than comes on the tray. At least that was the case in 1990 when we did the study, perhaps still the case. The group that got the exercise plus the supplement, they still ate their normal amount of dietary food, but they also increased their caloric intake by about 300 calories a day, which was the amount in the supplement. The group that got just the supplement itself, very interestingly, didn't actually increase their dietary intake because they stopped eating about the exact same amount that was in the supplement. So this is what happens in a hospital when you put a can of Ensure or something like that on a hospital tray. People will perhaps drink the supplement, but not eat the food. So, and we were very careful to give the supplement at night away from any dietary intake, but they still, because they had no reason to eat more calories in this dietary group, they actually just stopped eating an equivalent amount of calories. So that's probably why just giving the supplement alone didn't make, any improvement in their muscle mass or their muscle strength. So that was 33 years ago, and I would like to say that things have changed in a good direction in residential aged care in that period of time. But unfortunately, as you would be very aware from the findings in the Royal Commission, the findings that we reported back in 1990 and beyond have not made their way into residential aged care. And I think this is the statement from the final report, that the prevailing model of care is largely reactive. Aged care services are not really geared towards enablement and do not maximize the maintenance or the improvement in people's health. And I think that's very, very sad to see that over 33 years, things have not really changed, but we need to do better. And that's clearly what the Royal Commission has told us. And I want to talk about a particular syndrome, geriatric syndrome of hip fracture, as one example of how we could actually do better. So hip fracture, as you would know, is a very complex geriatric syndrome. Depending on who you are, if you're an orthopedic surgeon, you think it's about osteoporosis. If you're a dietitian, you might think it's about malnutrition. If you're a geriatrician like myself, you probably think it's about everything under the sun. And there are so many risk factors for hip fracture that allow people to actually end up like this, that just fixing the broken hip is really never going to be the answer to hip fracture. And the problem is that how you see hip fracture will determine how you treat it. So if you see it as a broken bone, You'll fix the broken bone, but you won't really fix the person around the bone. So there have been studies done asking people how they feel about going into a nursing home. In general, people in the United States in a recent survey have said they would rather die than live in a long-term care facility. And a study that was done at Hornsby Hospital a few years ago for women with osteoporosis, asking them, if you fractured your hip, what would you be more afraid of, dying or going into residential aged care? And uniformly, they said they would much rather not go into residential aged care. They would prefer to be dead than actually live in a nursing home in the Hornsby area. So that's a pretty negative statement about what we're doing in residential aged care and how we could probably do better. So when we looked at hip fracture a few years ago to see, well, what is it that causes such disability after hip fracture, and encourages or allows people to go into residential aged care and even have early mortality, all of the things on this screen are the things that are actually predictors of poor outcomes after hip fracture. And in the hip fracture literature, poor outcome is actually defined as death or nursing home admission, which is, again, a pretty damning statement about the quality of aged care. But that's what is called poor outcome in the hip fracture literature. So when we looked at this list, we thought, well, when you look at that, a lot of that is actually things that are treatable. So the problem is not really that we can't treat hip fracture properly, but that we're really thinking about it as a broken bone, when what it really is a syndrome of frailty and sarcopenia that needs to be treated quite differently. So we did a study called Hipfit at Royal Prince Alfred Hospital, where we took men and women who'd fractured their hip, and we had, as the core of the program, we actually had high intensity weightlifting exercise, very similar to what we did in the nursing home in Boston. You can see the exercises that we did here. And again, we didn't water it down or do it any differently than we ordinarily would. We used a high percentage of their peak strength and progressively increased that over the year of training. The other thing that we did, however, was we paid attention to all of those other risk factors for poor outcome after hip fracture. And we said, well, whatever's wrong with them, we'll treat it. So they had weakness, so we gave them weightlifting exercise. They had fallen and broken their hip, so we gave them balance training. We looked at their home for safety and mobility impediments. We gave them hip protectors if they wanted to wear them. Calcium, we treated their self-efficacy, low self-efficacy. If they were malnourished, we gave them supplements and other kinds of ways to increase their functional activities around meal preparation. We looked at their drugs and deprescribed hazardous medications, gave them vitamin D if they needed it, treated their depression, treated their visual impairment, treated their cognitive impairment, gave them support services. And so in addition to fixing their broken hip, we actually treated all of the other remediable components that were a pathway to poor outcomes after hip fracture. And you can see that a lot of people needed, obviously, the core of the program. Most people needed nutritional replacement. About half of them needed vitamin D, depression, cognitive impairment treatment, and social support, sort of at the bottom there. And on average, by our screening tools, people needed 10 of these different treatment arms. And that's probably a very good explanation as to why just giving people hip fractures replacement, replacing their broken hip, and even giving them a few weeks of physio is never going to be a sufficient treatment of this condition. So what happened when we did this? Well, what we saw at 1 year was that we were able to reduce this outcome called death or nursing home admission, as well as the two components of it, by about 85% compared to usual care. And usual care, remember, is an orthogeriatric team and 12 weeks of physio. That's usual care. But compared to that, we could reduce death or nursing home admission by about 85%, which means usual care is not good enough. And the outcomes actually continued to be better, about 65% reduction, even at year 2, after we had stopped intervening for an entire year. So when I look at this, the takeaway message is we know how to make people better. We know how to give them better quality of life. We know how to keep them out of nursing homes, but we're just not doing it. We're not doing it in a robust way that needs to be done. And that, I think, is what the Royal Commission has emphasize to aged care providers and consumers is that there are a lot of concerns, and many of them are some of the same things that we were concerned about in Hipfit: food and nutrition, dementia care, inadequate use of mobility to prevent the need for restrictive practices. And particularly food, I think, is something that many witnesses to the Royal Commission emphasized was completely inadequate, both the quality and the quantity of the food, and this certainly needed to be improved, because a recent survey has suggested that almost 70% of aged care residents were either malnourished or at risk of malnutrition. So that's pretty horrifying, that we have people in our care that we are meant to be taking care of who are actually not getting enough food and drink. So diet, nutrition, hydration, critical to the health of older people, and in addition, well-being. So providing a sense of enjoyment through food is also something that is very important. Most of the aged care providers were failing to meet these very basic human needs, in fact, human rights needs for food and drink. And malnutrition, as you would well know, is associated with falls, fractures, pressure ulcers, infections, rehospitalizations, worsening of dementia, etc. So many of the other components of frailty that we're trying to deal with are actually made worse when somebody is also malnourished. So again, we do know what to do. This is a very good book, which is open access, so you can download it for free if you like. And it has a lot of very good management practices for aged care, both in the community as well as in residential aged care. And what's really nice about it is that it talks about this interdisciplinary management. So it's not just about dietitians putting more food on the plate. It's about how all of those other healthcare professions, as well as physicians, are important for the management of malnutrition. And the reason for that is malnutrition is complicated. This is just a pyramid you can see of all the different things that can be risk factors for malnutrition in older adults. And if you look at this list, those of you who work in aged care, you'll see that you might easily have a patient who would have 75% of these things going on at once. So is it surprising at all that almost 70% of aged care residents are malnourished? It's not at all surprising. And because this list is so complicated, there's no way that a single healthcare practitioner could really cover all of these bases. So it's such a complex problem, like frailty itself, that we need to do better at seeing how depression affects malnutrition, how surgery does, how dry mouth and oral dentition does, how loneliness, living alone. If you look at the books written by Bill Thomas, the very famous geriatrician who invented the Eden alternative, what he says in his books is that what's killing people in aged care is actually loneliness. He said that was the biggest killer of people in aged care, and part of that is also related to malnutrition. So if we're going to deal with this, we have to assess it. This is in this book a mnemonic that can help you remember all the different things that go into assessing and treating malnutrition. But the first step is really to figure out that somebody is malnourished. It's not rocket science, but we need to do it. And then once you do it, is actually figure out all of the treatable contributors to malnutrition and try and fix them as much as you can, in addition to providing better quality food. And knowing how much food somebody is eating is very important. So I mentioned in our Fix-It study, we had 3-day food weighing, which is a very labor-intensive way of documenting nutritional intake. That's never going to happen outside of a research study, but it doesn't really need to. And simple tools for either videotaping, what's left on the plate, or having simple charts like this often is the first step to actually recognizing that people are not eating enough food. So for nutrition and frailty, certainly diagnosing what is the cause of malnutrition is important. Low vitamin D status is obviously a very important factor in nursing home residents because of the lack of both intake as well as sunlight exposure. Implementing PRT. So why is that? Well, I showed you from the Fix-It study that people who got weightlifting exercise, because it is anabolic, it does increase your appetite. If you give them more food, they will actually eat more. If you just give people food and they don't need it, they're unlikely to eat more. So one of the ways of improving people's nutritional intake is actually giving them the anabolic stimulus to increase calorie intake and then incorporate protein into new muscle cells. So very important. Adding high quality protein and energy supplements if it's needed, if food intake is not able to be sufficient, then, and particularly in adults who are undernourished, that will actually improve the outcome of the anabolic exercise. And very, very important, we think about nutrition in very clinical ways sometimes, but the joy of cooking and eating and eating in company is something which is hugely important in residential aged care and is probably the thing that's left out the most. And I think many of you may know that Maggie Beer in 2014 started the Maggie Beer Foundation. You can look up this website and watch her videos and download the materials, but she has actually dedicated the rest of her life, she has said, to improving nutritional status of people in residential aged care. Which is really quite phenomenal when you think about it. But she has decided that this is her mission. There's some fantastic materials that she's developed, and there are a few nursing homes in South Australia that have taken up the charge and are doing this. Not enough of them, I would say. But for those of you who are perhaps not dietitians, but who love to cook and eat, this is another way that you can get involved in residential aged care improvements. The modules that she has under development, all of which is free, you can see on the screen here, but a lot of it is about not just providing the micronutrients that that the government requires, but really providing the aesthetics of food and the pleasure and joy of eating, which has been missing. There's a study that was done in 1984, which showed that when you took people in a nursing home setting and you had a researcher go and touch them on the shoulder, just touch them, not even speak to them, touch them for 1 second before they ate, the ones in that group compared to the controls had a 25% increase in their food intake. So 1 second of human contact was actually enough to increase food intake by 25%. So how much, malnutrition could we change by that simple fact of human contact? So very, very important to change the current status of nutrition in nursing homes. The other part of the report that very relevant is restrictive practices. So restrictive practices can be the physical restraints and the Haldol that my grandmother was on, but it can also be the inability to allow people movement around the nursing homes, preventing people from using stairs, preventing people from going outside, putting them in jerry chairs, which don't look like a physical restraint, but they actually are when you don't have the leg strength to get out of them. So without clear justification or indication, many of these restrictive practices have been in place for decades in nursing homes in Australia, in America. It's been a problem that has been recognized for many years, but it hasn't really changed. What we've done is we've gotten rid of the physical restraints that are visible, and we've replaced them with pharmacological restraints, which are no better and perhaps even worse because of the damage that they can cause cognitively, as we'll see shortly in this presentation. So the inappropriate use of unsafe, inhumane, restrictive practices is rampant. And as the aged care report says, it must stop now. So all of you listening to this webinar, it should be your mission to get rid of the very inhumane practices that are prevalent in residential aged care. The Australian Law Reform Commission has gotten involved and considers it a human rights issue. But despite the fact that you are meant to get permission, for example, to put people on pharmacological restraints, many times they are actually used without that family and caregiver permission, which is really not correct. So deprescribing becomes a very important feature of residential aged care and reimagining it. All of you are familiar with the deprescribing principles, recognizing it, prioritizing medications to get rid of, weaning people off things, and monitoring withdrawal symptoms. When I look at this, I see a lot of hesitation to get rid of drugs. In fact, I think it's very conservative. It looks as though, you know, there might be more risk stopping drugs than not. And I think that's actually not true. I think, as you'll see, stopping drugs is probably the least of the problems in terms of polypharmacy. But if you are going to treat people well, you need to assess them very thoroughly, know all of their medication history, figure out what the drugs are treating. Every disease and drug should be matched up. There shouldn't be drugs that have no disease that they're linked to. Assess what's going on in terms of side effects of drugs. Interactions between drugs, nutrition, and physical activity are very important. Monitoring adverse events. So very, very important to do that. So it is part of policy, as you would know, in residential aged care in Australia, that people have residential medication management reviews, or RMMRs. This is a program that's been in place for a number of years now. This report here identified that this review process is important, that when you review somebody, you identify something like 3 different medication-related problems per resident. And if you bring that information to the GP, depending on what GP you're talking about, somewhere between 45 and 84% of them will actually try and optimize the medication management to get rid of those medication-related problems. So it sounds like it's a great system and it's working. However, in this report that was just released in March of this past year, they actually reviewed all of the different residential aged care facilities in Australia to see whether the guidelines, which recommend that everybody should receive this medication review on admission or whenever their circumstances change, to see whether or not it was happening. So they reviewed 27, almost 2,800 residential aged care facilities, followed them for almost 2 years. They found that most on admission, residents were receiving 11 different unique medications, and a majority of them had received at least one high-risk medication. However, when they looked at what happened, despite the fact that this is considered to be part of residential aged care management practice, only about 20% of residents actually got one of these reviews within 3 months, and only 50% within 2 years. And in that time, a lot of the residents had actually died without ever getting a medication review. So we have this system which sounds great, sounds like it's, you know, picking up problems, and that GPs are responding to those problems. But in fact, the vast majority of our residential aged care residents are not actually even getting a single medication review. So that's, again, a problem that needs to be dealt with. The final area that I want to talk about is mobility. Mobility is certainly something which is needs to be addressed. And back in 1988, when we went into the nursing home for the very first time, and I asked people, I said, we're going to do a weightlifting study. How many of you here want to lift heavy weights? And this crowd of 90-year-olds, not one of them raised their hands. But finally, this little man in the front row raised his hand. And I said, because I said, well, how, what would you like? Would you like to live longer? What would be a reason for you to take up exercise? And he raised his hand and he said, we don't want to live longer. We've been through the Holocaust. We're 90 years old. He said, what I want is, I want to be able to get up from my chair, walk to the bathroom without calling the nurse, turn around, come back down and sit down. That's what I want. And I said, well, I can give you that. That's what weightlifting will do for you. So this idea that mobility is such a crucial component of quality of care is really, really central to what we want to do. Poor mobility increases the risk of falling and injuries and deconditioning. Tying people down because they're at risk of falling makes them more at risk of falling. And yet that has been the approach in residential aged care, tying people down physically or tying people down pharmacologically. So there, as the Royal Commission has said, there is a clear overuse of physical and chemical restraint in residential aged care. So the rationale for integrating exercise into the care of older adults is that there are a lot of changes of aging that are attributable to disuse that are not really aging, but are actually just a component of that disuse. So I showed you Sylvia, who at age 96 has lost no lean body mass over 11 years Why is she so unique is because most people her age are not lifting weights, and they're not using their muscles, and so they're aging in a very premature way. Secondly, many chronic diseases obviously increase with age. Exercise is an independent way to both prevent and treat most of the major chronic diseases and the causes of morbidity and mortality in older adults. Third, traditional medical interventions don't typically address all of the disuse syndromes, such as frailty and sarcopenia, which are really often responsible for the disability more than the chronic disease itself. And finally, some of the pathophysiological changes that are central to aging are maybe better addressed by exercise than pharmacological interventions. So if we look, for example, to compare exercise and medication effects in terms of peak fitness and body composition, exercise affects all of these things in a positive way. We have no drug that does any of these things. We have no drugs that makes your aerobic fitness better, that makes your metabolic fitness better. But we have exercise in children as a way to actually help people reach peak fitness. When you think about preventing risk factors for chronic disease, again, exercise has been shown in lots and lots of studies to treat these risk factors. Other than using metformin to prevent diabetes with glucose intolerance, we don't have drugs that actually prevent any of these conditions, but exercise does all of those things. When we get to treatment, this is where there are lots of drugs. And again, exercise is adjunctive or complementary to many of the drugs that we use for all of these major chronic diseases of aging. So again, complementary use of exercise. But when we get to age-related changes in physiology and function, we do have drugs for osteoporosis, obviously, but we don't have drugs for poor balance, for sarcopenia, for increased visceral obesity, for declines in aerobic capacity, all of those things which exercise does very well. So when you think about somebody who's in a nursing home who has accumulated years and years of chronic disuse, disability, chronic diseases, there's a huge rationale for trying to add exercise to the medications that they might take. So that's the background as to why it's important to think about mobility, polypharmacy, nutrition, exercise. I want to give you an example of how you can put all this together in a very typical, perhaps, nursing home resident, because it may seem like it's too much to change the paradigm that we have. But my feeling is, just as it was back in 1988, just as it was back in 1972 when my grandmother broke her hip, that in fact we can do better. So this is the case of Max and his wife, Lisa, who have kindly allowed us to share his story and his videos, both in print, where we've published his case report, as well as in these kinds of talks. So Max, when we first met him, was 86 years of age, had dementia with Lewy bodies, as well as, you can see here, COPD, osteoporosis, sarcopenia. He lived in a dementia unit where his wife, Lisa, very devotedly visited him daily. However, he was very lonely because he was one of the only men in this unit where he had been placed due to his falls risk. He had fallen and fractured a couple of ribs, after which he was catheterized, given sedation, as well as pain medication, contracted a UTI, developed delirium, had a fall and a head injury with a seizure, and went to hospital. So a typical kind of story from a nursing home resident. And since his hospital stay, he'd actually been bedbound. A hoist was used to move him around. He was seatbelt restraint to stop him from getting out of his bed and falling. He had a suprapubic catheter, which was now placed. He'd lost a tremendous amount of weight, initially 10 kilos, and then overall 15 kilos, which was 20% of his body weight in only a few months, 8 months altogether. He'd been put on a pureed diet because he was thought to be dysphagic. And he wasn't eating much of that, was very fatigued and sedated. So a horrendous story of this gentleman who actually started out to have only moderate dementia when he went into the nursing home. Hopefully you can hear this. Just tell me if you can't. But this is what Max looked like when we went to him to be part of our research study. And at this point, he was on a number of medications, had lost the 17 kilos. And you'll see him here trying to respond.
Matthew, sitting up tall for me. That's better.
So that's him responding to his wife and the trainer telling him to sit up. So he's able to understand them, but obviously not do much else. So when we looked at him, these are the medications that he was on for very unclear reasons, having the audacity to try and get out of his chair, I guess, and fall. So you can see there a list of medications, many of which would be in the category of PIMS, potentially inappropriate medications, a couple of opioids, drugs that can cause falls, atorvastatin that he probably didn't need, obviously, at his current malnourished state. So a lot of things going on that were probably contributing to the way that you saw him in that particular videotape. I came on the scene as a geriatrician, not as his attending geriatrician, but as a geriatrician doing a research study on exercise in people with Lewy body dementia. Luckily, the GP that was treating Max was willing to actually listen to my suggestion that maybe he didn't need pretty much any of these drugs, and they were all stopped, with the exception of albuterol, which was just a PRN inhaler. All of the rest of them were stopped. I did mention in that slide about deprescribing that you're recommended to do them sort of one at a time, make sure there's no problems. We actually stopped all of them pretty much at the same time because it didn't seem that there was really any indication for pretty much any of them. We also stopped his pureed diet because he didn't seem to have any trouble swallowing, and put him back on the food that he liked to eat, which was going out for a beer and a hamburger with his wife, Lisa. So all of these meds were stopped and reduced to just a PRN inhaler and vitamin D at the end of the day, with the exception of his medication for seizures, which he really didn't seem to need, but that was the one medication that they wouldn't stop. So that was the deprescribing end of the story. The real purpose of our research study was to do exercise, and so we were paying attention to what the frailty consensus guidelines says, which is that we strongly recommend that resistance training be the center of the exercise program. And why is that? Well, if you think about somebody trying to get out of a chair, what do you need to stand up? You need strength. What do you need to stay up? You need balance. And what do you need to walk across the room or the nursing home? That's where your aerobic capacity comes in. But trying to do it in a different order, trying to stand up and walk without having the strength to get out of a chair is actually inappropriate. Flexibility training or gentle exercise, stretching, none of that really has any role to play in terms of getting this gentleman out of a chair. And yet when you look at nursing home exercise, so-called exercise programs, primarily they are stretching programs. And they really don't attend to this statement or any consensus guidelines about the treatment of frailty and sarcopenia. Once somebody is able to get up and stand up and stay up without falling over, that's when walking can be added. And if you add it in a different order, if you let somebody walk who doesn't have sufficient strength, that's been shown to actually increase the risk of falls and fractures. So the order in which you get out of a chair is the order in which these different modalities of exercise are needed. So that's what we did with Max. We had rehabilitation initially in the nursing home, where we had him do knee extension, trying to use his triceps to get out of a chair. Once he was able to actually get up by himself out of a chair and transfer into a car, we then drove him 3 times a week to our clinic at the university, where we had him do high intensity progressive resistance training, just like we did back in 1988, which then were complemented with other kinds of walking and mobility exercises. And you'll see here, I'm not going to show you all of this, but when you get this video, you'll be able to see Max as he's just beginning to now exercise in our clinic. And you can see that he still needs quite a bit of help getting out of a chair. And his lovely wife, Lisa, always on the scene.
1, 2, 3, go, 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 go.
So you can see after our rehab in the nursing home, he's able to partially get out of a chair by himself. You can see he's got pretty severe Lewy body dementia there, but he is able to understand the commands of the exercise physiologist. So I'll let you watch the rest of that later. But what our main training for Max, as it is for anyone with sarcopenia, is high intensity strength training, and in his case, power training, because we're trying to get him to move as fast as possible. So you can see him do a power training leg press exercise here.
Breathing out and push, 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 push. Good. Come back in, Max. Come all the way back in. We'll keep those knees in.
So he's trying to go as fast as he can. The external velocity is not that fast, but it's as fast as Max can go. So what you see there is exactly what we do with people who have no sarcopenia, have no Lewy body dementia. We don't actually water it down at all. We use 80% of his peak strength as the load that he's pushing against. And we'll show you here as he's now been training for 7 or 8 weeks.
1, 2, 3, up.
There he is getting up without any assistance, just some contact guarding. The crowd is cheering. I hope you can hear that. And you can see him taking a few steps without even holding on to his walker.
Keep going, keep going. The walker's there if you need it, but we're going to keep walking as normally first, okay?
If you think back to that man tied in his jerry chair, drooling, unable to get up, was that his Lewy body dementia? Was that his advanced age? Or was that drugs and malnutrition and being tied in a chair? So what we see is this progression. When we first met him, he could get out of a chair by himself. After he was falling and restrained and on several drugs, he was unable to get up by himself. Then he was severely malnourished, really unable to even barely respond to communication with him. And then 8 weeks later, simply 8 weeks of training, he's able to actually get out of a chair. He still has Lewy body dementia. He's still 88 years of age, but he's now mobile and has obviously a very different quality of life. And when we look at what happened to him, you can see now the intersection of poor nutrition, polypharmacy, mobility impairment, pharmacological and physical restraints. So when his body weight went down by 17 kilos, you can see him going here from 74 to 57 kilos. At the same time, his skeletal muscle mass went down, his mini mental went down from 21 to 13. His SPPB score went down from 5 to pretty much 0. This green pit here is 8 weeks that we trained him in our research study. Everything goes up in parallel. And very unfortunately, when our research study was over and he sent him back to his nursing home, to the typical residential age care that he receives, everything went sliding back down to where it was before. So unfortunately, COVID struck and didn't allow us to bring him back into our clinic for further care. But this very, very tight interaction of all of these different components makes the case that the Royal Commission is so clearly stating that people in residential aged care need all this variety of allied health and physician input all together, because everything affects everything else. And yet, even at this incredibly advanced stage with the SPPB of 0 and a weight of 57 kilos and a mini mental of 13, just giving him back food and mobility and resistance training is able to actually improve things. So how to use exercise as medicine? Certainly you can prevent things that we have no other drugs to treat. You can certainly substitute for less effective or more hazardous forms of treatment. For example, using an antidepressant rather than exercise for depression is hazardous when you're 85 years of age. Augmenting the effects of other kinds of treatments, offsetting the side effects. If somebody's on corticosteroids, for example, and they're losing muscle and bone, you need resistance training to offset the side effect of that medication. And then countering changes in physiology, which are risk factors for morbidity and mortality. That's how exercise needs to be used as medicine. And because it is medicine, the need is to recognize it as having the same kinds of dose response effects that other kinds of medicines have. And for resistance training, the most important part about the prescription is not the volume, it's the intensity. So you don't need much volume. Once or twice a week even can be sufficient if you do it at a very hard or hard to very hard level, which is about 80% of the strength that the person has. That's the level that we typically train people at, that in many, many studies now has been shown to be the most optimal for improving sarcopenia and frailty. Obviously, you don't take away treatment. That's treatment for frailty and sarcopenia. So the longer you train people, the better. Higher intensity is better. 2 to 3 sessions a week seems to be optimal. And it's not a high volume. So it's something like 45 minutes of training 2 to 3 times a week seems to be what's needed. It's very clear from systematic reviews, high intensity is better than moderate. High intensity is better than low intensity. So there's really no point in having people lift light weights. It doesn't do as much good. It doesn't take any less time to do it at the proper intensity. So you might as well do it in a way that is most effective. And if you do it that way, what you will see is very rapid gains in strength, just like you saw in Max over 8 weeks. He was able to get out of a chair by himself and walk without his walker. And the gains continue as long as you continue to increase the load. And it's been shown that up to 2 years, you can increase muscle strength. And if you look at somebody like Sylvia at age 96, she's still actually maintaining her strength after 11 years of weightlifting exercise. Unfortunately, what we see in the community as well as in residential aged care are very inappropriate forms of exercise, which are not weightlifting exercise that is properly performed. Although this ad here says that it will improve your strength, balance, and flexibility, this isn't the way that we train people for sarcopenia. It's not going to help somebody who has a hip fracture. It's not going to help somebody with immobility from Lewy body dementia. So don't waste your time with things that are not proven. Exercise is a drug, so you really do need to use it as a drug. How do you incorporate it into healthcare, whether it's in the community or in residential aged care? Know when you can use it by itself, like for depression, or when you can use it as adjunctive treatment, like for heart disease. Prescribe it specifically, not generically. If you came to me and you said, I'm sick, doc, help me, and I said, well, I think you should take a drug, that's about the way most doctors say to people, you know, when they say, what should I do? They say, well, I think you should be a little more active. Not good enough. Exercise is a drug, so you need to prescribe it like a drug. It should be part of all standard healthcare settings. There is no setting that I can think of that does not deserve exercise as part of it, and using evidence-based program in those settings. These days, we're using a lot of remote supervision to help increase adherence, and obviously recording that just the way that you would record other kinds of treatment. As much as possible, involving caregivers and volunteers as exercise buddies is a really good way to do it. Here's an example of somebody with severe sarcopenia in our cognitive aging study, again, doing power training on the arms and the legs, you can see there. This person does not have dementia, but they do have mild cognitive impairment. You can see he's able to do power training a little faster than Max. And even in the dialysis unit, we've done high intensity weightlifting exercise in dialysis unit. This arm is exercised before they're hooked up to the machine, and the rest of the body can be exercised during the dialysis session. At St. George Hospital, we had a study where almost all of the participants in the dialysis unit were lifting weights at one point in time. So turning what is normally kind of a, almost a morgue-like atmosphere into a gym-like atmosphere with this kind of exercise. So again, you can watch the rest of that video at your leisure, but there really is no healthcare setting that does not deserve exercise to be added to it. And even in the acute care hospital, this is a tremendous study done by Miquel Izquierdo a couple of years ago in Spain, where he took older adults who were admitted for an acute hospitalization, pneumonia, other kinds of things, and he had them do power training in the hospital twice a day, in the morning and the evening, as well as balance training. And he showed that when they did this, compared to the hospitalized patients who did not exercise during their hospital stay, even though it was only about 5 days long, they had improved cognition, improved function when they left the hospital compared to the usual hospital stay. And as you know, hospital stays result in functional decline, often recurrent hospitalization and falls. And so he's now promoting this kind of exercise in hospitals throughout Europe as a way to mitigate some of that functional decline. And what about in the nursing home? Well, you can do it if you try. So this is a study that we're currently doing in Queensland called FRIEND, which is basically, and although we thought of this before the Royal Commission report came out, frailty reduction with exercise, nutritional support, and deprescribing, called FRIEND. So really taking all of those very remediable components of poor function in a nursing home and trying to treat all of them at once. So we put in a bunch of our weightlifting machines in this empty space in the nursing home. We even have some portable leg presses that can be wheeled around to the hospital beds of people who aren't able to come down to the gym area yet. And we'll be working with this very, very integrated, holistic team of allied health professionals, students from JCU, the CEO, the nurse manager, really everybody on board, volunteers, caregivers, so that we can actually try and do what the Royal Commission said we must do. So it's time to do it. I think that this is a research study, but really in clinical practice, it's been far too long now. It's been many, many years that we have been ignoring what to do. If you have equipment like this, certainly the outcomes will be better if you have access to it, but you can use portable weights if that is all that you can do in your particular setting, at least as a starting point. But if you can get somebody to fundraise for $5,000 for you and buy a leg press, by all means do it, because it's probably going to be the best investment that your facility has ever made, I would say. So the Royal Commission, again, allied health professionals should be there. Allied health should be an intrinsic part of residential care. So that's what we're doing in our research study. But really, there's no question that the kind of care that people are receiving in Australia is so inadequate compared to what we need to be doing. Frailty is not inevitable. It's not untreatable. And rather than being a barrier to robust exercise and other kinds of interventions, it's the most important reason to prescribe it. So not everybody's going to look like Ernestine Shepherd here, who started weightlifting at age 50 and she's now 89 in this photo. Not everybody's going to look like her, but they certainly don't need to look like this woman. We can certainly do better, I think. So I think reducing the morbidity and mortality of frailty requires a huge paradigm shift, where we have to see things like sarcopenia, depression, isolation, loneliness, malnutrition as primary. These should be the primary focus of our treatment. These things are much more remediable than the osteoporosis little Annie Nyman here has. So her T-score is minus 3.5. We can't help that, but we can feed her, we can give her weightlifting exercise, we can treat her depression, we can give her support at home, and it doesn't matter that her T-score is minus 3 or minus 3.5, because everything else around that bone will actually be the determining factor for her to go home and walk to the store and feed her cat every day, rather than end up in a nursing home. So how do we make it better? Just imagine your future self. Where would you like to be if you're frail? Would it be the kind of residential aged care that we have now, or would it be some reimagined aged care, perhaps like the Friend nursing home in Queensland, or something even better that actually isn't a nursing home, but some other way of living that is probably more dignified than an institutional setting? So I think I'd just like to end there. And I think I would like to thank all of the students and research assistants and colleagues who have worked with me for more than 3 decades now to rage against what is clearly inappropriate care for our loved ones. And as always, I dedicate this and all my lectures to Helene Freundlich, our first volunteer at the age of 96, exercising with us until she was 103, Holocaust survivor, pioneer, nonagenarian weightlifter, and really a symbol of what you can do with just a little bit of imagination. So thank you.
Thanks, Maria. That was a fantastic presentation. Just so great to listen to. We might take some questions now if we can. If you just type your questions into the questions box there, we'll read them out for Maria. And we've also got Gabe and Beth on our panel as well to help answer any questions that come through. Maria, just while people are typing in questions there, are there any countries that sort of stand out in taking the charge, in making the change that residential care needs?
I mean, I think it's a little bit better in some of the Scandinavian countries, in Sweden and Norway. I think what's better is a different way of thinking about aged care that is less institutional, so smaller homes. And in fact, in Sweden, the same support, if you want to age at home and age in place, no matter how frail you are, as opposed to going into a residential aged care, they will pay for the support services to do that. So I think home care is much better than it is here, which allows people to age in place. Because, as I said, when you ask people, which would you prefer, death or aged care, it's death, which is a really marked sort of indication of how bad things are. So I think there are some countries that are making their headway. And in my perspective, I think there will never be a perfect nursing home situation, perhaps. They need to be smaller. They need to be more personalized. They need to be Edenized. If you haven't read the Eden Alternative, I would very much advise you to pick up Bill Thomas's book. And when he talks about reimagining the nursing home and Edenizing it, he takes away all of the institutional sort of structures, the hierarchy, the departments, the fact that you have to get up at a certain time, take your meds at a certain time, and he turns it back into a home, which is really what's needed. And I think this idea that you could do it in an institutional setting is really where the problem is.
We've got a couple of questions that have come through. This one's from Alice. Educating patients on the benefits of exercise is something that she finds challenging. The patients might have cognitive impairment, limited by pain or lacking motivation, etc. Do you have any advice that you could give
Well,
her?
actually, in my experience, the barrier has always been the caregiver, not the caregivers, the health professional staff, nurses in particular, but also physios and people who aren't aware of the benefits of exercise. As I said, if somebody says, well, what I want to do is stand up by myself without calling a nurse, and you can say, well, here's how you get there. You strengthen those muscles in your legs, and you'll be able to walk independently. That's incredibly motivating. So in my experience, the barrier really is on the other side. It's in institutions and systems and people who are a little bit afraid particularly of robust exercise. And so once people see that, they can now lift up a bag of groceries by themselves and walk down the hall by themselves, that's the motivation. If somebody's cognitively impaired, maybe you can't, educate them, if that's the word, but you saw those videos of Max. I hope that you could hear him, but if you do get a chance to listen to what was going on in those videos, even though, his mini mental score was 13, he was able to understand that this exercise was making him able to walk and to go out and, into the community and have lunch with his wife. And so even, with some dementia, you're able to do it. If somebody has severe dementia, that's a different story. And perhaps, just getting them to sort of follow along and mimic you is really all you can do. But I really don't find the motivation of patients to be the barrier in my experience.
Gabe, from an OT perspective, is there anything that you could add to what Maria has said there?
Only that I really feel like I'm nodding and agreeing, Maria. I agree. Some of the systems that we have make it really challenging to ensure that we can support those residents, those consumers, to be doing what they want in those environments. And it's sometimes really hard to break down those barriers, and especially the timeframes in those barriers too. But there is so much opportunity in that, in working in inpatient settings with people with severe and persistent mental illness. One of the amazing things has been around having food or having a morning tea around that exercise activity or whatever we're doing, and the enjoyment and the sense of satisfaction that people get out of that is just fantastic.
Thanks, Gabe. We've got another question from Emma. Should this information and research be more widely shared with younger age groups?
Well, definitely. I mean, I think, when the reason I sort of presented those slides about, how exercise works throughout the lifespan, clearly, you can start exercising, as a child and adolescence. And if you want to get your bone mass up to its peak, you need to do it before 20, because that's when your peak bone mass is reached. So preventing osteoporosis, preventing sarcopenia, preventing frailty is a lifelong thing. Absolutely. And I think, certainly people are more aware of it than they used to be, but there's still, I think, particularly for sarcopenia, there's a lack of appreciation that, the most important change that's going on in your body as you get older, is that loss of muscle mass. If you ask a child, what an old person looks like, they will stoop over, walk slowly, get up, hard to get up from a chair. Muscle weakness is the key feature of aging. And the nice thing is, we have this antidote. We have this antidote that can protect you from it, and yet very few people are using it. So, in Australia, only 10% of older adults lift weights at any intensity, and probably most of them are probably pretty low intensity. So only 10%. So 90% of people or more are at risk of developing sarcopenia. Sylvia is an anomaly at age 96, lifting weights 2 days a week for 11 years. And that's where the problem is, that there's been a push to do aerobic exercise that's been in the literature for many years. Although resistance training, has been in the literature for 40 years now for older adults, or 35 years anyway. It still hasn't really made the grade, particularly with physicians. I would say, most physicians don't really see weightlifting exercise as medicine. Whereas for me, as a geriatrician, it's the most powerful medicine we actually have. There isn't anything more powerful than weightlifting exercise, full stop. Nothing is more powerful. So why don't we pay for it? Why don't we have practitioners in nursing homes delivering it? Why aren't there leg press machines in every nursing home? Why aren't we telling people to do it at home? Why is there no Medicare rebate for an exercise physiologist to go teach you how to do it? It's because no one thinks of it as medicine. If we did, we would pay for it the way that we pay, you can pay for metformin for life to prevent diabetes. And yet we know from the diabetes prevention study in the United States that metformin was no more effective than placebo in older adults in preventing diabetes, but exercise and diet was very effective, 60% reduction in the risk of diabetes with diet and exercise, including weightlifting. And yet Medicare will pay for metformin to prevent diabetes, but we don't pay for diet and exercise for life to prevent diabetes. So it's a policy problem, it's an institutional problem, it's a physician education problem, to me, far more than it is even a consumer problem, I would say.
And Beth, could we hear from you about the diet side of things? Maria's just mentioned diet and exercise being the two greatest things that you can offer. Can we hear from you about how that can help our older people?
Oh, absolutely. I mean, nutrition obviously is right through Maria's presentation has been so critical as well. And I found it so interesting to talk about that study where someone touched someone on the shoulder without discussion, and it still prompted an increase of oral intake. That we have so much work to do still around improving the environment in aged care, as well as the quality of food provided. But there probably is, when you're referencing younger people, there probably is a lot of education work still to be done that many people don't realise. As you age, your protein requirements go up. And often people need nutrition advice to actually improve their diets to meet their requirements around protein. It's not necessarily just going to happen naturally that someone will increase their protein intake. And there's so many different barriers around, food people like the taste of, appetite levels, taste changes related to health conditions, ability to chew and swallow, and then budget as well, that have an influence around what food people can access or what's provided in aged care. I could talk nutrition for a long time. I'm sure Maria could as well. There's so much it would be great to change.
Yeah,
But
I would really
that's it.
encourage
Look, I
everybody
would
to
have to
look at.
say some of the nursing homes I go to are being very innovative in terms of what they're putting in place, and certainly Maggie Beer is being a lot of that training. Even facilities in our Central West are picking up on some of those tips and doing their best to try and make the food more interesting and more accessible for
And
aged
also
care
getting the
residents.
residents involved. There are some nursing homes that are letting the residents help with the cooking and the preparation of the vegetables and growing garden. And so if you think about it, all the things that you love about food and eating, it's all stripped away, right? And you're in this environment where the food comes to you on a little tray and you have no connection with it. There's no way that that people are going to eat properly in that setting. So as much as I think that's why I said, imagine your future self. What would you want if you were 90? You would still want food that smells good and tastes good, that you're sharing with your friends, that you're having a glass of champagne with, that is aesthetically pleasing. And all of those things are far more important than the sort of micronutrient dissection of it that we get to, because if you give people enough food, they'll get their micronutrients. And if you give them exercise, particularly anabolic exercise, their appetite will improve, their muscle mass goes up, their appetite is tied to that. So it's all a very much a vicious circle or a good circle, depending which way you look at it. You can't look at it in isolation. That's why I think the Royal Commission was absolutely spot on, the way they linked those things together. And nicely enough, our little case history of Max, which I didn't make up a word of, is absolutely, he's the star child of the Royal Commission. He is exactly what they were talking about. And if we hadn't come along, I'm sure he would have died tied to that chair, losing weight down to 45 kilos. He's a tall man, so he's very thin. So, he's the poster child for what goes wrong. And yet you can see that 8 weeks later, you can actually change him into a different person, which is remarkable. And it just shows you how much of it is us, how much of it is just, we're not doing the right thing. We're not taking care of our loved ones the way they deserve, full stop. So, yeah.
I've got another question from Greg. He's asking how hard it is to access exercise physiologists, especially regionally, and he was wondering how they're engaged or referred.
Yeah, there's certainly far fewer of them regionally than there are in the cities. We're proposing a study now where we're trying to do a lot of telehealth sort of to the regional and remote areas, because there are very few of them. But on the other hand, you don't always need an exercise physiologist. So over the last 35 years, I've trained everyone to do weightlifting exercise and help other people do it. So dietitians, OTs, rec therapists, nurses, doctors, family members, social workers, lab ward secretaries, children. So you can actually train almost anyone to do this properly, in my experience. And if people have a medical background, so that they have that sort of knowledge, you can add the exercise knowledge to them. So I'm not saying that exercise physiology has nothing to offer, but I do think we need to be a little bit more broad about our the way that we actually implement this kind of exercise. And I would much rather have a dietitian giving somebody weightlifting exercise in a nursing home that has no exercise physiologist than say, oh, well, you can't do it because you've got no EP there. That's just kind of silly, because, you can train people to do it themselves. So obviously you can train other healthcare practitioners to do it with them or for them. So, but I think we need to, break down those walls in the nursing homes. In Queensland, we're going to try and bring in students, bring in family members, bring in volunteers, so that, all of the students will get a chance to work with these aged care residents, but also we can supplement the paid staff of the nursing home with these volunteer workers. And the same thing could happen with nutrition. Same thing could happen with beauty. Beautician students could go in there and be doing manicures and hairdos. I mean, all of that should be happening, right? Because it's it's their home, or it should be their home. And so all of the things that we like to do, getting a mani-pedi and getting our hair done, should be available to aged care residents. And a way to do that would be to bring in a lot more volunteer services and students who need to do training and how to do haircuts. Well, why don't they practice, in nursing homes as opposed to, young students in in the community? So we just haven't been creative enough about bringing the, breaking down the walls and bringing the community into the nursing home. And why isn't there a daycare center in every nursing home, for God's sake? The staff is all women, childbearing age. They have to leave their children at a daycare center somewhere and go to work. Why don't they just bring their children to work, to the nursing home, and have the older people who are there who can do it be part of the caregiving staff for the daycare center, right? So they're actually giving back to the staff. So, it's not rocket science. It's really just thinking about what you would want for yourself or for your mother or father, if they were in that situation. And then, we just need to change it. We need to fix it. We need to stop saying, oh, it's too hard, too expensive, can't do it. We need to stop saying that, because it's not true. You can change it. You can make a difference. Absolutely.
Okay, being based in Orange, do you have any insights into that exercise physiology referral pathway?
Yeah,
I can find out for you. If you email me, I will check with a friend who would know and find out. Yeah.
Yeah, thank you, Maria. We do have a couple of options, I guess,
we've been looking into this
locally.
for another project, so it's definitely an issue. But like I say, I think we need to just broaden our perspective and train other people how to also deliver exercise if you can't get an EP. Yeah.
Yeah, absolutely.
Sorry, Gabe, is there anything you wanted to add there?
I'm not an EP. I'm a geriatrician. I learned it all myself. So obviously anybody can learn it.
We do have another question from BJ. He's wanting to know if there's a comparison study of deconditioning at home versus residential care.
Yeah, of training people at home, is that what you mean? Or
I'll get BJ to just clarify there if he can.
or whether people get more frail at home, is that, or
So BJ said yes.
of
So by
training
that you
people at
mean
home, is that?
training people at home in the deconditioning level, I guess, versus residential care?
Well, I mean, if the question is, can you train people at home? Yes, it's more difficult. We've done a couple studies of home-based weightlifting, and it's more difficult because you don't have the proper equipment. You're using, sort of ankle weights and dumbbells and things. So it's hard to get to the right intensities and progression, but you can do it. And obviously, weightlifters train with free weights. That's how they train. And so there's nothing wrong with that method. It's just hard to get the proper equipment in that setting. So if there's any way you can get somebody even once a week to a proper facility that has machines and then do the rest of it at home with body weight or free weights, that's probably a better option. So there are studies showing that home-based training has positive outcomes, but they're not as great as center-based kinds of programs.
Question now from Jewel. If a resident with severe cognitive impairment and aggressive behaviours, how would it be possible to incorporate exercise without triggering those behaviours in that person?
Yeah, well, I think it's very individual. So, I mean, I think, obviously it would be nice if the person that was working with that resident had a relationship with them and, there was a level of trust. And obviously behavior, changes kind of minute to minute sometimes. And so there might be times of day which are better than others. There might be, relationship to meals, either one side or the other that works. But I think it's probably a matter of just, picking your time. And then making probably very short bouts. So some of the same ways that we work with people who have schizophrenia or other kinds of mental illnesses, we often have to be very particular about the time of day and the length of the session and distracting, environments. And obviously you probably wouldn't have somebody with, that level of behavioral disturbance in a group class of some sort. You'd probably do it one-on-one. And maybe you do it in their room if that was a safe place for them. But I do think that, the idea that you have to, quell all of that behavior, with restraints is really overdone. And sometimes you need to be able to, let the person, have certain behaviors if they're not harmful and violent, obviously. And it might be that you could distract some of that behavior with some kind of engaging exercise, but I would say there's certainly not one way to do it. It would have to be very, very individual, and the key would be to develop some level of trust with a particular either healthcare worker or caregiver or family member, who could be the one to deliver it, I would say.
Now from Michael. First off, he says it was an excellent presentation, Maria. Thank you. He wants to know how allied health can be enlisted routinely in aged care facilities for assistance at point of entry. And that rural access, I guess, is a problem.
My understanding is that the Royal Commission now has recommended, obviously, that there's payment for visits. I think there's, last I heard, 5 visits for an allied health professional to go into residential aged care will now be reimbursed by Medicare. I think that's correct. I mean, correct me if I'm wrong, somebody. But that was my understanding as of a few months ago. Obviously, it's insufficient. Again, the analogy to diabetes, somebody has diabetes, they need insulin, you don't give them 5 syringes and then say good luck to you. If you have sarcopenia, if you have frailty, you need exercise forever. And so at the moment, I think the probably the way around it is to have your 4 or 5 visits that are paid for, and then perhaps engage the family members as the way to keep on delivering it if there's nobody else in the staff to do it. So at the moment, we just do not have the infrastructure set up, that the government is not paying for it. And so it's either out of pocket. Some people do pay EPs to come into the nursing home and work with their loved one, and they're just paying for it themselves. And that I do know that happens in some nursing homes. But I think we need to get more creative. We need to get students in there who are doing internships and clinical placements, volunteers from the community who can be trained up to deliver certain kinds of care. So I think we need to broaden the scope until the government gets on board and says, well, yes, everybody deserves, good food, good exercise, the right drugs, and we're going to pay for that, as part of their aged care. And that's what the Royal Commission report does say, that it should be paid for. Essentially, that access to allied health should be part of government funding. So wait for the law to change now.
We've got a question, sort of comment from Anthony. It's very challenging to think about how these allied health services can be funded and provided in the Western New South Wales residential aged care setting. What's the expected impact of the Royal Commission findings on funding these services? And you've just touched on that, I think, Maria, in that last response.
What I read in it was that, the one recommendation, that one of their final recommendations was that that they be increased, and I'm pretty sure that Medicare enacted that last December and now pays for 5 visits of some allied health professional into residential age. Is that right? Yeah, maybe you can know more about it.
I don't know all that much more about it than, yes, it is available. It's maybe just that partnership and system between both the GP and the aged care facilities in getting on board and prompting that conversation each time the GP comes in, so that that chronic care plan or the systems that are being used are signed off and there's that access to allied health.
Right, so GPs need to be educated that, now it's available, use it. So they're aware of it, obviously, for their chronic care plans in the community, but they're probably not yet aware of it in the nursing home. And to me, the problem is this lack of optimism. It's this idea that, Max is there tied in a chair, drooling all over himself. It's as good as he's ever going to get, right? I mean, who would look at him realistically? Who would look at him and say, I can help him? No one. No one would, right? No doctor would. I swear to, and yet we looked at him and I said, I can help him. I am sure that part of his problem is drugs, malnutrition, being tied down, being isolated. I'm sure of it, right? And those are things that I can absolutely help. But that sense of optimism is missing, I would unfortunately, from a lot of GP. I think a lot of people who do aged care visits are not necessarily, it's not necessarily their vocation. You know, they might, you know, it's kind of a way to make a little extra money, go nursing home patients, go see them once in a while. It's not their vocation. It's my vocation. It's my life. You know, that's all I've ever wanted to do is fix that problem. So for me, you know, it's completely obvious that you can help. But I don't think that's the case for most physicians. I think there's a few that, you know, probably love old people and love geriatrics and love frailty, you know, and are on board with it. But I think they're few and far between. I think even among geriatricians, I think it's few and far between, unfortunately. So how can you expect, you know, GPs and other people who don't really have a vested interest in aged care, you know, to be on top of it? So you know, to me, it has to come from the ground up. It's Lisa, you know, Max's wife, calling and saying, yeah, I want him to be in your research study, you know, come and see him. And you know, and the nurse is like, he's too frail. I don't think he can participate, you know, but she's an advocate, right? She's like, no, I think he can do it. If she wasn't there advocating for him, we never would have known Max existed. He would have been tucked away in his little dementia unit, tied down, nobody to talk to, you know, nonverbal demented patients around him forever, right? But she, as his advocate, you know, found us. So, you know, it shouldn't take that. It shouldn't take a, you know, random research project that happens to be in his nursing home, you know, for that to happen. That's the issue, is that we need that sense of, you know, optimism and, you know, just, yeah, very, very, you know, out of the box thinking about what's possible. I think that's really what's needed.
I'm just mindful of the time. It is 8:30, so we might, if it's all right, have just one more question. So from Greg, the medication review on admission to residential care is a great idea, but if they had a home medication review or one of those MMRs in the last 24 months, the funding isn't available. So that's fairly limiting.
Yeah, I mean, unfortunately, you can only get it every 2 years, which is crazy, right? Although I think it does say on admission and with any change in status. I think that's the law. So, you know, if you're clever and you know, make it look like there's been a change in status, maybe you can get another review. I don't know. I mean, again, you know, maybe we're making it too complicated. You know, I'm not a pharmacist, right? But I can do a drug review. I can figure out where are the drug nutrient interactions, the drug exercise interactions, the drug interactions. And I can do that without necessarily invoking some other kind of administrative process. And any doctor should be able to do that, in my opinion. So I think that, you know, we've set up this system where now it's regimented, it's this formal process, you know, but it's not happening. 80% of people are not getting a review on admission. So, and then if they get it, the next one they can get, like you say, is 2 years later, way too late. So I think we just need to stop making things so complicated and stop making money the barrier, and, you know, realize that it's imagination or lack thereof that is the barrier.
Thank you so much, Maria, and thank you to everyone who's attended tonight, and special thanks to the panel as well, Gabe and Beth, for your input there with the Q&A. If you have a moment, please scan the QR that's on your screen there to complete an evaluation survey for us. We'd really appreciate it. We will try and make Maria's PowerPoint slides, including the videos, available to you, and please, yes, share those around, because I think the more we get the message out.
Just so you know, you're welcome to share them if it's helpful for any educational purposes in any place you're working. You're more than welcome to share them. I have permission from all the patients to do that.
Fabulous. So yes, please share and get the message out, and hopefully change will come. Thank you everyone so much for coming tonight.
Any questions, happy to answer.
I'll pass Maria's contact details on tomorrow as well. Thank you everyone. Good night.
Thank you.
Thank you, Maria. That was fantastic. Thank you.
Thanks, Beth.
Thanks.
Thanks, Gabe.
Thanks, Maria. Thank you, team.
Thanks. Good night.
Thank you.
Thanks, everyone.